Recording in progress. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this afternoon in this scientific event, which is in collaborations with the GSK and the Saudi Society for Family and Community Medicine Riyadh office and organized by FEXUS. And in these sessions, I'm sure that is going to be very important topics we are going to discuss, and it will highlight all the challenges that we are coming across in the day-to-day practice in the terms of maternal immunization. I would like to introduce myself first. So today we are going to talk about the Tdap, maternal immunization, the current barriers and strategies for optimal coverage. And this is constitute a challenge for all of us, and we are going to learn what are the challenges and the barriers, and then we'll put the strategy to overcome these problems. I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the Vice President of the Saudi Society for Family and Community Medicine, Honorary Assistant Professor of Al Qura University. So I'm privileged today to be with you here as a moderator and a chairman. Before I start, I would like just to pave the way and to shed light and to set up the stage for our topic today by saying that the overwhelming majority of the morbidity and mortality attributed to infection by the pertussis infections usually occur in the infants at the age of 2 months and below. And we all know that the infant vaccination series starts after the age of 3 months. So usually there is a gap. There is a gap, in fact, which we call it immunity gap, that leaves those infants viable and under the curve of having these kind of infections during this period of time. So this gap has to be filled up by certain interventions, which is the maternal immunizations. And if we just look into the study which was published by the CDC in 2017, for the children's age less than 1 year with pertussis disease in the United States, it has been found that there is about 50% of them, they require hospitalizations. And this is another burden on the healthcare system. Not only this, but also the hospitalization rate was much more higher for those infants below 3 months, and this was followed by those who have been in the age of 3 to 6 months. Not only this, but also the complication which was reported, not only confined to the respiratory system in terms of apnea, 61%, and pneumonia, which is 23%, but also it's hit badly the central nervous system by causing convulsions and encephalopathy by 0.03%. So the mortality was 1 in 100 infants, those who have the pertussis disease in the United States. And for this, we are going to have certain objectives in our meeting today. The first objective is to highlight the burden of pertussis disease in infants and the importance of maternal immunization. So we have to know exactly how big is the problem, and to it we are going to intervene accordingly, and we are going to find out what are the different barriers for the improper coverage of the vaccinations uptake for the maternal immunization. To leverage the discussion to highlight the local and global recommendations for the Tdap vaccinations. So we'll be knowing what are the updated recommendations, and then we are going to highlight an important specialty that we have to have it as a member of the medical team, the midwifery, in supporting maternal immunization as integrated part of the healthcare model of care. Now we are talking about the multidisciplinary team approach and the patient-centric approach. So adding the midwifery specialty definitely will add a big value to cover all the immunization for the maternal coverage for the pertussis. And then we are going to have a review of vaccinology, clinical evidence, efficacy, and effectiveness, and the safety profile of the Tdap vaccinations. With this, we have been privileged today, ladies and gentlemen, to have our distinguished speakers who are going to be representing the specialties and the expertise. The first one is Dr. Muhammad Athaniyan, who is an epidemiologist and public health specialist, and Dr. Garid Ad-Dosari, she's a consultant family medicine in Sulaiman Al-Habib Hospital, and Dr. Ru'a Al-Tawiri, she's a consultant midwifery, assistant professor King Princess Noura University, and the president of the Saudi Association of Midwifery, and then Dr. Mansour Khalaf, he's a director of the medical group of vaccinations in GSK company. So I hope that this session will be quite informative for all of us, and this will highlight that we are going to go through the agenda. So we are going to talk about the burden of the pertussis, and this will be delivered by Dr. Muhammad Athaniyan. Unfortunately, he is not able to join us physically, but he's going to join us through online. And then we're going to talk about the challenge in vaccination uptake and the improvement of the Tdap, maternal immunization in Saudi Arabia, the role of my midwife in Tdap, maternal immunization, and review the evidence of the Tdap vaccination, the efficacy, the safety, and the durability. And then we'll open the floor for discussions. And I'm very privileged to say that we are joined by more than 1,000 attendees virtually. So I'm sure that the discussion will be quite. So please prepare your question till the end of the sessions, which is going to be 2.5 hours from now. So without any further ado, I would like to introduce the first speaker, who is Dr. Muhammad Athaniyan. He is an epidemiologist and public health specialist. He's going to talk about barriers, and he's going to talk about the burdens of pertussis in infant. So I would like to welcome Dr. Muhammad, and I would like to leave the floor for you, Dr. Muhammad.
السلام عليكم.
عليكم السلام ورحمة الله.
يعطيك العافية دكتور أشرف. Thank you so much for your introduction. I'm happy to be joining this session discussing the Tdap immunization in maternals. I would like to share my screen now to start our session. Is it clear? Okay. So good afternoon, everybody. Thank you for attending today. I know it's a Friday, but yeah, this is an important actually a topic to be discussing. The burden of pertussis disease in infants. My name is Mohammed Thniyan. I'm the National Vaccination Coverage Unit Head at the Ministry of Health, part of the API team. So I'm just a disclosure from JSK. So I'm not a JSK employee, and I have received honoraria from JSK for this presentation. This slide was developed in collaboration with JSK. So just most of you definitely are aware of pertussis, but let me just remind you here about it's an acute infectious disease, usually affecting children, caused by pertussis bacteria. It starts with a mild fever and can develop until becoming a cough, characteristically cough. So that's why it's called the whooping cough disease as well. Clinically, it's lasting for 2 weeks. um, and paroxysmal cough, inspiratory whooping cough, and post-tussive vomiting. Coming to the epidemiology of the disease, the incidence actually is always highest in children or infants younger than 1 year, and that's showed in so many studies, whether here in Saudi Arabia or even globally. We can see here that there is a high incidence rate in the US from a paper, a study conducted in 2018, also in England. And as Dr. Ashraf mentioned, in the ages of younger than 3 months, which is before the due date for the first vaccination dose for the Tdap. Also, it's shown in New Zealand and also in Brazil. Coming to Saudi Arabia, these two graphs actually shows an important message showing the incidence rate and for pertussis. If we compare the two groups ages between all the incidence ages in Saudi Arabia and comparing it to younger than 5 years, we can see here that the incidence rate, if we're going to focus in the latest years, let's say from 2016 until 2019, we can see the incidence rate is around 55 per 100,000, while in the ages of younger than 5 years, it jumps to 794 cases per 100,000. And this is actually, if we can look at the latest years, we can see a slight shift actually in the curve, that there is an increase in cases in the last few years. And that's actually concerning. It means that we're not having enough immunity in the population of younger than 5 years. This is another study, despite the efforts conducted globally for vaccination, which is the best invention that humanity made in the field of medicine, that there is still a gap in this immunity. Okay, and younger than 2 months of ages, despite that there is a 10 years improvement in the whole public health system, but still the gap is there. The incidence is always high, and this is shown between 1980s and 1990s. So as Dr. Ashraf mentioned, I would emphasize on the idea that there is an immunity gap, and it is
It
from
is
birth
birth
until
and
2 months of
2 months
age,
of
which
age.
is the due date for the first immunization
Immunization.
dose for Tdap for infants. So this gap should be actually addressed and filled. And that's why then ITAG and WHO recommendations insisted on the idea of introducing the Tdap for pregnant ladies, and shifting from only one vaccine, or actually to a vaccine covering only one disease, which is the tetanus from TT, to cover three diseases for the to become the Tdap. This is another study conducted in England and in the US, and as it shows, as I mentioned before, it's obvious that there is a gap, and there is an immunity gap in the ages less than 3 months of age. And it's concerning that this is increasing in the last few years. There is a hesitancy increasing from parents to vaccinate actually their children. It's not just that there is the immunity gap until the first day's due date. There is a hesitancy increasing as well. So, coming to the burden of the disease, unfortunately, there 50% of
50% of
children
children
actually
actually
having to be
having to be
admitted in the
admitted in the hospital.
hospitals. apnea is there is a higher rate. 61% of children with pertussis having apnea, 23% having pneumonia. These complications are a huge burden financially on the health system itself. When we come to the ages specifically, that was 50% for ages less than 1 year. When we come to the ages of less than 3 months, which is the ages of not yet being vaccinated, it reaches 93% of children having pertussis to be hospitalized. That's a big number actually. Again, there is a hospitalization. This is another a study in 2017 from the National Notifiable Disease Surveillance System in the US. We can see that ages always is the highest ages and cases of being hospitalized is younger than the due date for the first dose. Um, and if we come to locally in the Eastern Mediterranean region, we have actually, although we have the resources, the first, let me say it in this way, the first region is Africa, and that is somehow understandable because of the lack of resources they have, the health system that is not well established. The second area is Southeast Asia. And that is because of the crowdness and so on. But when we're in the third region, Eastern Mediterranean region, we have an incidence rate of zero 0.7 of morbidity, and mortality is 11.3. Although we have the resources, we have a good health system actually, but we are still in the third place. So that would lead us to consider, since the surface is there, the system is there is a gap in most probably it's the knowledge or the willingness for vaccination. So if we come to Saudi Arabia in 2019, there is a huge spike in cases. It's always the same age, but the numbers are spiking. There is two reasons for that. The hesitancy most probably has increased, and from an internal person who's working in the surveillance system itself was improved. That's why we catch actually more notified pertussis cases. Coming to the recent years of 2020 and 2022, the cases are the number of cases decreased actually, but that wasn't because of the routine vaccination, rather than actually we had a system to catch up what we had the lack of vaccination during the pandemic. So that was an extra effort actually to catch up for children who've been losing their vaccinations because of the pandemic. This is a comparison actually between the vaccination rate and the incidence rate of pertussis. As we can see here, there is a huge spike of cases in 2019 with the decrease of uptake and utilization of the vaccine itself. Okay, that was noticed by the EPI team, and there is certain steps to being taken to catch up with these defaulters and children. The hesitancy actually is increasing, and that's concerning, and that actually increases the our responsibility as healthcare workers. We can after each pandemic, the hesitancy always increases. WHO mentioned that there is some countries, the hesitancy rate of routine vaccination increased to 44% points in certain areas and certain countries. And this is not the first pandemic that we faced, and the hesitancy rates increased for the routine vaccination. We're not talking about adult immunization or campaigns. We're talking about the routine child immunization. This actually spiked. There is a lot of papers mentioning that there is an increase in hesitancy. And this is not for this COVID-19 pandemic, even the Spanish flu, the same thing happened in Europe, the same thing happened in North America. And there is certain steps to be taken to against and to face this hesitancy and anti-vaxxers. The schedule has been for the adult immunization has been updated from TT, which is for tetanus toxoid, to become Tdap for adults, including pregnant ladies. Also, MMR was recommended as well for the same reason, the gap in children that they are not due date
due
for
date
the
the
first dose
first
of
dose
that
of
vaccine.
that.
So to address that hesitancy and lack of vaccination in children, we need to vaccinate the mothers so they can pass the immunity through IgGs to their infants. There is two aspects actually addressing these this gap or giving the vaccine for the pregnant ladies. We need to focus on the healthcare workers and their responsibilities, as well as a community-based health promotion. So for that, we should the practice-based or practice focused for healthcare workers. They should be trained. They should be standing orders for the vaccine. Um, Healthcare workers held a huge responsibility for vaccinating, for actually addressing this issue. Unfortunately, I'm hearing from my colleagues that we are facing a hesitancy actually within our healthcare workers, within our staffs. They are actually hesitant themselves to take the vaccine, as well as recommending the vaccine for their patients or for their family members. This is actually an issue. I think we need to have more trainings, more sessions, such as this one, to talk about the safetiness of the vaccine, to talk about the efficacy of the vaccine, and why we are recommending this vaccine actually. The knowledge itself, the scientific knowledge of research on the safety of the vaccine and the efficacy of the vaccine, I don't believe it's enough. We need also to touch bases on the idea of why we are doing that, why we are having such more vaccines and expanding or giving more expanding in the target population. Such explanations can help the healthcare workers, even themselves, to send that message for their own patients. The communication skills they have for addressing any concerns from the patients they're seeing. Such speeches are important. Such approaches are important, as well as the community or patient-focused practice. I know most of you, and I understand that healthcare workers they have a very limited time to give for their patients because of the crowdness of the clinics. That's understandable, but that doesn't mean that we should have less than optimal service. giving time to the patient, addressing their concerns, and recommending the most appropriate health practice they can give, including the vaccine, offering the vaccine, educating the patient. All of this can actually increase the uptake of the vaccine, and can compete with the hesitancy and the issues we're facing. Thank you so much. I'm definitely here for any question if you have it. Thank you.
Thank you so much, Dr. Pertis, on go all through the challenges and the barriers of vaccinating the maternal immunizations and achieving the target. So now we'll move to, because of the sake of the time, we'll move to the second speaker. Second speaker is Dr. Gharid Al-Dosari. She's a consultant family medicine in Dr. Suleiman Al-Habib Hospital, and she was an ex-director of Women Health at Ministry of Health. So I think she's going to bring the privilege of having both parts of sectors of the private and the government together to give us her opinion and her expertise in women health and tackling this kind of big challenge of maternal immunization. So the topic of Dr. Gharid is the challenge with the vaccination uptake and improving the Tdap maternal immunization rate in Saudi Arabia. So welcome, Dr. Gharid, and thank you for being with us here today.
Assalamu alaikum. First of all, Jum'ah Mubarakah for everybody. Inshallah, today we will talk about the barrier to vaccination. First of all, I'm Dr. Gharid Al-Dosari. Thank you, Dr. Ashraf, to introducing me. Thank you, everybody, to be here with us. Can I click? All right. It will be like this, my picture and yes, it's better like that. So today, inshallah, we're going to talk about the barrier of vaccination during pregnancy. So I love to start, maybe the sound is loud or it's okay? Okay, good. So I like to start with this slide because it's very essential component of a preventive healthcare. Immunization, it reduces the incidence and severity of vaccine-preventable disease. So pregnant women and neonates, we know they are exposed to infectious disease due to their altered and undeveloped immune response. Vaccination during pregnancy, it will provide maternal protection through active immunization. Active immunization, so it will start from the mother, while passive maternal antibody transfer across the placenta to her fetus. So prior to vaccination, it's, as we said, there is a barrier. So they highlight it in 3 reasons. First, the lack of surveillance system. Yes. During my ex-work, we have this issue. We have a lack of surveillance system. We don't know exact number for the patient who received the vaccine. The lack of confidence in vaccinating pregnant women among healthcare workers. Some of the doctors, they hesitate. They know it's safe, but they still hesitate to give the vaccine to the mother. The third one, the hesitancy of pregnant women for the vaccine. طبعا we know after COVID, all the pregnant lady, they become more hesitant because of the rumors regarding the vaccination, and it will affect me. And it's been before. If you told them that tetanus replaced by Tdap, it's the same, but the efficacy more. So here we just talk briefly about our study done. Alhamdulillah, it's published 3 months ago. So this, it will help us to understand the barrier among maternal immunization. We start with introduction. Here we highlight that we know who's working in Ministry of Health. Nobody. Do you know 2019 they start to update the national immunization schedule to be from to the woman from 26 to 36 weeks? So alhamdulillah, this is done 2019. Ministry of Health recommended the pregnant women all receive vaccination from 27 to 36 weeks. So our aim was to review the literature on safety and effectiveness of maternal pertussis vaccination and to identify strategy to improve maternal immunization rates in Saudi Arabia, also to assess the knowledge and attitude of obstetrician and gynecologists toward the maternal pertussis vaccination in Saudi Arabia. طبعا my experience, as you said, in Ministry of Health, the majority of patients seen by primary care doctor, but in the private, they go direct to the gynecologist. So, a document reports result of online survey conducted an inadequate market, independent market researcher agency on behalf of GSK, asking 60 obstetrician and gynecologists about their attitude to maternal pertussis immunization. The document also summarized the evidence from various studies that show the impact of maternal pertussis vaccination on preventing pertussis disease and hospitalization in infant, as well as the safety outcome of Tdap vaccine during pregnancy. So as we see here, 50% of the doctors, they know about a recommendation. And as we see here, maybe it's not clear, and at the point I cannot, the first line, for the reason why patient not taking a vaccine, what do you think? I know you cannot read, but I know the answer. What do you think? Patient refusal, thank you. Patient refused to take but our job as a doctor, even the patient refused, okay, we will accept the first time, but second time, our job to educate her also. She had more than 8 visits. So if we start this question in the first visit, her subconscious will start to understand and she will be convinced during that. So the conclusion, it was a strategy to increase maternal vaccination rate in Saudi Arabia need to include education of physicians, pregnant women, and public about the disease and the benefit and risk of vaccination. Rationale. Here, I love this picture so much. They put the mother. Why? Because she's responsible for the period here and here. She is the responsible for this period. So the mother, when she received the vaccine, she passively she give it to the infant. So the infant, they are not vaccinated from 0 to 2. So who will be protect this period? The mother, immunization. So after that, the baby, the infant will start to take 2, 4, 6, and 18, preschool and preteen, and for the older adult. So older adult, we know as a family, if the mother, she received the vaccine, so it means the baby, inshallah, protected. But if the mother, she didn't take the vaccine, and the elderly people who's living in the same house, it will be also benefit for the infant. So here, also this picture showing what we said, the line, the gray line, it's maternal immunization, and the scatter if she didn't take the vaccine. So as we said, here, it's increased at birth, so it will still up during this 2 months. When you start the vaccination, it will go up. And opposite, that if she didn't receive the vaccine, it will dropping immediately. So here, this is regarding the immunoglobulin, how it will start. So in the first weeks of pregnancy, it's let's say none. So it will start from the week 13. So So it is increased by 5 to 10% by 17 to 22. Then the 50% will increase between the 28 and 32 weeks, exceed the maternal level by full term, it's 20 and 30. So here, this is for the benefit of, this is a study to show the benefit of vaccination. So in England, the maternal vaccination program started 2012, and it was recommended that from 28 to 32. Then 2016, they extend the time to be from 20 to 32, and sometimes they give it even before 16 weeks. This study showed that, as we see here, the hospitalization cases in the full term is still the same, but for the preterm, they get the benefit. They decrease from decrease from 20 to 9. So this also give us a hint that even if we give earlier for the preterm, it will be more protective. So recommendation, this slide, it's recommended WHO, CDC, FIGO, all recommended for the maternal immunization. It's safe, WHO said safe, highly effective, high impact on morbidity and mortality, cost effective, more effective than cocooning. CDC, Tdap during pregnancy also, they provide best protection for mother. FIGO, they recommend to vaccinate women from 27 to 36 weeks, and this is what we are doing here in Saudi Arabia. Here, despite the recommendation, still below optimal, as we see here, United States, 57%, England, Netherlands, still suboptimal. Yani we want it to be more. How we improve the uptake? Dr. Thanayan, he showed this slide. As we see here, there is two parts. Some of them, 70%, they offered the vaccine. 30%, they recommend it, but they don't. And less than 5%, they don't know. For the patient who is unaware, so it's our responsibility because we didn't tell them. Concern about the safety also, this is all the pregnant. Even if you give her Panadol, sorry, Yani. She said, is it safe? They are always scared about anything they taking during pregnancy. And some of them, they said it's not recommended by a healthcare provider. What's the intervention? From the doctor again, from the doctor educate, and we have to educate and train the staff, use a standing order. We help them to add, if we are like in administration, we help them to improve a system that to add reminders, and this is, we did it by the way, to the patient in medical record, assigned vaccine campaign, documentation, it's very important. For patient-focused, recommended and educate, provide strong and direct recommendation for vaccination, over vaccine, and educate the patient. We have to educate the patient. It's her right. It's her right and educated. If I know sometimes the clinic it's busy, and this is not excuse at all. Even we have to give at least 2 minutes to give her, what do you know about this? What do you know about this? Because some of them, they trust us. All of them, they trust us. And if you give them the advice, they will believe on it. So we have to give from our clinic time to educate the patient. So the motivational intervention, ask and the question. patient, she come in the first, she knows she's pregnant, we give her folic acid, blah, blah, blah. It's good, but we ask her, do you know what do you have to do during the pregnancy, during your journey? So there is vaccination. Give her time to read about it. Give her time to convince about it even. So, and be good listener to the patient. And if you are hesitate to give the answer, don't say, I don't know. I will ask, and I will let you know in the next, this is communication between our patient. We have to build a good relationship with the patient. So next time, we have to put a note, this patient, I have to answer her. Even if she didn't ask next time, I will give her the answer, so she will trust us more. So then I will be listening and give her the information and advice and summarize. I think here also, as we see, this is the vaccination card for adult. It's, even if we mention that they believe on Ministry of Health, let her look to this. Some of them, they don't know about this vaccination card. So show her the pictures. Tell her, see, this is one of the recommendations of Ministry of Health. Over 40 countries, we see. The light gray, it's not vaccinated. The dark gray, it's vaccinated. And alhamdulillah, Saudi Arabia started this program for vaccination. Inshallah, we will reach the optimal, inshallah, rate soon. And needs of our work together. Okay? Thank you so much.
Thank you so much, Dr. Gharid, for this nice presentation, shedding the lights on the challenges in the uptake of adult vaccination with a special focus on the Tdap for maternal immunization. And you have highlighted the tools that you can use. And I think one of the very important things that we have to keep it in mind all the time, the motivational interview, how to master this kind of communication skills and how to get the opportunity to tackle the missed opportunity of having a lady who's supposed to have the Tdap without, and leaving the organization without having the vaccination. So thank you so much for this, Dr. Gharid. And now to explore another perspective of our scientific event, which is the role of midwives in Tdap maternal immunization. And for this, we are privileged to have Dr. Ru'a Tawili. She's a consultant midwife, and she's assistant professor at Noura University, and she's the president of the Saudi Association of Midwifery. I think this is another interesting topic to learn, and this is another era for collaboration with a new team who's going to join us, inshallah, as a supportive team to enhance our uptake for adult vaccination with a special focus on the Tdap. So, Dr. Ru'a, thank you for being with us here today. Looking forward to listen to you.
Good afternoon, everyone. Thank you, Dr. Ashraf, for your kind introduction, and thank you, everyone, for attending this important event about the maternal immunization. And I'm very happy to be invited to speak about the role of the midwives in the Tdap vaccination, and I thank the Saudi Society of Family and Community Health for inviting me to this event. So I will talk today about counseling pregnant lady for vaccination and the role of the midwives. And this is the speaker disclosure of, I'm sure you have read it. I'm not a JSK employee, and I have received honorarium from JSK for presentation, and this slide was made in collaboration with JSK by me with full responsibility for unnecessary third-party consent, and content is consistent with local product label. Okay, so by the end of this session, you will recognize the importance of midwifery profession and identify the role of midwives in vaccination during pregnancy. So what is the definition of the midwife, or what is the ICM, International Confederation of Midwives, definition of the midwife? A midwife is a person who successfully completed a midwifery education program that is based on the ICM essential competencies for basic midwifery practice and the framework of ICM global standards for midwifery education, and is recognized in the country where it's located, who has acquired the requisite qualification to be registered and or legally licensed to practice midwifery and use the title midwife, and who demonstrate competency in the practice of midwifery. Is there any midwife here attending? No? One? Two? Okay, good. Here as well? No? Okay. So it's very important for us to know what is the scope of midwifery practice, because there is a lot of relation between family physician, between the obstetrician, between the nurses and midwife. So we need to know where is our scope. So the midwife is recognized and responsible and accountable professional who works in partnership with women, give necessary support, care, and advice during pregnancy, labor, and postpartum period, to conduct birth on the midwife's own responsibility, to provide care for the newborn and infant, preventive measure, the promotion of normal birth and detection of complication in mother and child, accessing of medical care or other appropriate assistance, and the carrying out of emergency measures, health counseling and education for women, the family, and the community, antenatal education and preparation for parenthood, women's health, sexual and reproductive health, and child care. And also the midwife can practice in any setting, including the home, community, hospitals, clinic, and health units. Okay, so there is a recent study by the United Nations Population Fund and International Confederation of Midwives and the WHO that midwife has an impact in preventing and reducing maternal and newborn mortality and stillbirth, and reveal that investing in midwife could save millions of lives. And this is the summary of the literature and the Cochrane review about how midwives play an essential role in ensuring that women have a safe, positive experience during their maternity care. So quality midwifery care is linked with rapid sustained reduction in maternal and neonatal mortality, reduce maternal and newborn morbidity, reduce intervention in labor like cesarean section, instrumental birth, and episiotomy, more spontaneous vaginal birth, better rates of breastfeeding, women feel more in control and involved in their birth experience, enhanced psychosocial outcome, increased birth spacing and contraceptive use, less preterm birth and lower risk of babies dying before 24 weeks gestation, and finally high rate of maternal satisfaction. So this is the recent publication of the Ministry of Health about the Saudi midwifery clinic standard. And what is the scope of this midwifery clinic? There is 3 categories. The first category is antenatal and postnatal care. Category B, sexual and reproductive health, and finally the basic women health. So the aim of this midwifery standard or midwifery clinic standard is to promote and support the implementation, development, and growth of midwifery clinics, services which provide holistic care to women and their family throughout Saudi Arabia. You can access this standard through the Ministry of Health website, and to know more details of what is needed for the midwife to open this clinic. So the responsibility of a midwife in midwifery clinic to take full and comprehensive health history, perform complete physical assessment and examination, assess antenatal risk factor, perform basic procedures, follow-up of pregnancy, postpartum and newborns, perform clinical investigations such as blood tests, ultrasound, and pap smears, prescribe and administer medication according to the scope of midwifery practice, health education and general guidelines for women and families, support breastfeeding, and finally prescribe birth control methods and provide sexual and reproductive health services. So what is the role of the midwives in vaccination? Midwives are the frontline worker providing maternity care for women in many countries. The role of the midwife includes providing information about and recommendation for maternal vaccination during pregnancy and for the baby in the postnatal period. So vaccination as recommended in pregnancy include those prevent influenza, pertussis, and tetanus, and now COVID-19. Vaccination for the newborn baby include hepatitis B. So vaccination in pregnancy has always been important. However, COVID-19 pandemic has shown brighter light on this issue. So it depends on the context. Vaccination for tetanus, influenza, and pertussis is recommended during pregnancy, and vaccination for hepatitis B is promoted for newborn. So what is the substantial role of midwife? Midwives are the frontline worker providing maternity care for women in many countries, and their role is to provide information, recommendation for maternal vaccination. They are a strong influencer in women's decision around the maternal vaccination, and they have a unique role in provision of care and overcoming a vaccine hesitancy. So for this to activate and work, we need to support the midwife with targeted education, mentoring, and supervision, and innovative way to ensure vaccine access. So what is the prerequisite for effective midwife role in increasing uptake? We need to give the midwife autonomy and ability to provide information and vaccination without additional barrier of separate appointments, additional referral, and prescriptions. So it will be part of the care of the pregnant women. Instancy, providing advice regarding vaccination, as well as being able to vaccinate at point and time of care. And we have to have a model of care that is giving the midwife standing orders for vaccination and making it easy for the vaccination. So there is a lot of research about what is the role of midwife in vaccination. So midwives who had adequate knowledge and training were more likely to recommend vaccination. There is an Australian study using an online survey of 300 women, or 300 also showed that majority of midwives supported maternal vaccination with influenza, with pertussis, and with who needs further training, 2 out of 3. So the need for training and counseling skill, one Australian study showed that midwives had received minimal or no training on vaccine communication, and their practice focused primarily on vaccine information, provision than recommendation and persuasion. A European study also highlighted vaccination, which reinforced the perception that vaccination was the doctor's professional responsibility and not the role of the midwife. This is differences on the impact of education and training in vaccination program in Australia and UK. So consulting midwife before a new pertussis vaccination program ensured that was to women and program could be successfully implemented. And in the UK program, where midwife received additional training, attended influenza and pertussis vaccination clinic throughout the influenza season, and attended the labor wards and maternity inpatient ward to provide vaccination to those women who were inpatient in hospital. So this was highly successful in ensuring high uptakes of vaccination and pregnancy. So the importance of provision of healthcare professional, especially midwife, with the information and agency to make clear recommendation to women and family. So a study have showed or highlight the importance of providing healthcare professionals, especially midwife, with the information to make clear recommendation to women. So at a global level, most healthcare professionals still don't recommend some vaccines like influenza to pregnant women, midwives seem to be more likely to express safety concern than other healthcare professionals and less likely to recommend vaccination for infectious disease. Including maternal immunization in usual antenatal care is a usual strategy or useful strategy that makes the role of midwife critical. So a study in 95 low and middle income countries showed that the majority utilized antenatal care to deliver tetanus vaccine. Vaccination was provided by midwife or registered enrolled or auxiliary nurses as part of the usual antenatal care. So countries that had good integration between the expanded program on immunization and the usual antenatal care program were more effective at delivering these vaccination services. So what is the key points to consider? We need to make integration by ensuring that midwives are part of the integrated teams delivering antenatal care and maternal vaccination, depend on the risk assessment for the midwife or the woman or pregnant woman, and then we need to empower them and equipping them to discuss the different vaccine with pregnant women. So what the pillars for successful midwives model? We need to give them education and training, professional development, the model of antenatal care services. We have to activate the role of the midwife in the antenatal care, and also midwifery continuity of care, where the woman see the same midwife or group of midwife from the time of pregnancy until after birth and following her with her baby. So this is a 5 model from ACM COVID-19 vaccination guide. This can guide you and guide your conversation with pregnant women in relation to discussing vaccination. You need to ask, acknowledge, advise, assist, and then assess. So who should have the conversation? It's our job and part of our responsibility as midwives. Don't wait for someone else to have the conversation, and we can and will make a difference. Remember, we regularly discuss vaccination against influenza, pertussis, and hepatitis B. So this is a final slide, the share. Menomic from the Center of Disease Control and Prevention, CDC. We need to share specific reason why the Tdap vaccine is right for pregnant women during every pregnancy. And we highlight the positive experience, personal or in your practice, that reinforce the benefits of the Tdap vaccine, address women's question, because a lot of women have a lot of question. They have heard a lot of story from their friends and family. So we need to address their question and concerns about the vaccine in plain, understandable language. Remind them that the vaccine protects her and her family from many other serious disease. And finally, explain the potential cost of getting pertussis, especially for the infants. So this is my final slide. Thank you.
Thank you so much, Dr. Ra, for this nice presentation, highlighting the role of midwives in enhancing the uptake of Tdap vaccination and maternal immunizations. And now we have changing our mind setup that we have a new member of our team that we have to include all the time. So now we are going to go for the last but the most important topic that will highlight the efficacy, the safety, and the durability of the Tdap vaccine. And we have here Dr. Mansour Khalaf. He's a group medical manager vaccine in GSK, and he will shed the lights on the review of the evidence for the Tdap vaccines, highlighting all the different spectrum of the safety and efficacy of the vaccine. So, Dr. Mansour, the floor is yours. Okay. I just want to highlight Just want to inform those who are attending with us virtually, please try to keep your questions in the Q&A box so we'll be able to pick those questions relevant to the topic at the end of this session. Thank you.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Hayyakum Allah. And Jum'ah Mubarak for all of you. Thank you very much really for being here today. It's really a pleasure and honor to have you all around in today in Riyadh in this scientific event. And thank you again, Dr. Ashraf, for being here and for the Saudi Society of Family Community Medicine for hosting and collaborating on this important session. Okay, so this is the agenda of my presentation. Speak about pertussis burden in infants, immunogenicity, data on maternal immunization, safety and recommendations, and then conclusion on maternal immunization. All right, so yes. The speakers before me, they have spoken about, the pertussis and the dangers of pertussis, and the burden of this disease in infants, especially between the 0 and 2 month, and the importance of the maternal immunization during pregnancy, as well as actually the value of discussion with the mothers or pregnant ladies in order to gain their trust and increase the immunization rate. Now, we have the vaccination, which is Tdap. Minister of Health, they have already recommended the vaccination since 2019, I think mid-2019. It's there in the schedule, and it has to be followed. Until now, the immunization rate is not really picking up. I think it's around 20% in Minister of Health and less than that even in the private sector. What I need actually to do right now is just to give you a clue and just give you an understanding of how effective is this one. Is it really effective? Is it really safe that we can give it for the pregnant ladies? And can we convey this message? Let's go and see what we have. Okay, so here it is actually a different countries that they have conducted their research on effectiveness of Tdap maternal immunization effectiveness in different countries, as I said. So Belgium is in Europe, Australia, and Switzerland, as well as in Asia. So let's look at those. So here, immunogenicity data on maternal immunization. In Belgium, the mothers, they took the Tdap and they have compared to unvaccinated control. And then they looks at the conclusion. The infants born to vaccinated women has significantly higher antibody geometric mean concentration at birth against diphtheria, pertussis antigen, and during the first 2 months, so they have been protected. The infants were protected, and that was really the proof from Belgium. Another study by Dr. Abu Raya in 2014, what exactly he measured? He measured again vaccinated versus vaccinated. And what again he found? Antibody levels to pertussis antigen in cord sera. So they have taken, once the baby born, they have taken a sample from the cord sera and they have vaccinated against the antibodies there. And what they found, that in cord sera were higher in Tdap vaccinated mother versus unvaccinated. Is another proof. And so on. Let's go to Thailand, which is again another Asian country. Mothers, Tdap, they have been vaccinated between the week of 26 to 36 of gestation. And what they found a higher ratio of cord to maternal antibodies when Tdap was given between 26 and 30 weeks. Listen, this is now something that's very important that we have in Saudi Arabia. We said that 27 to 32 weeks. Now they have, again, they have measured between 26, 30 weeks versus 31 and 36 weeks. So they found the longer interval between vaccination and delivery led to higher cord antibody. So whenever that we have a longer between the delivery and vaccination, that will lead actually to higher protection to the infants. And this is very important. As soon as we should not wait actually more than this period to vaccinate. Number one, she might really go for preterm, or we might really miss her from the follow-up in the primary care center. However, longer interval could be really the solution. Okay. In this slide, what I want to present, Tdap administration showed efficient transfer of pertussis specific to geometric mean concentration. So in pertussis in particular, there are 3 antigens. The first one is called pertussis toxoid, second one is called filamentous mononucleotide, third one is called pertactin. As you can see, between vaccinated and unvaccinated, vaccinated mothers, which is the gray one, unvaccinated is the black one. And for the 3 antigen, it shows a significant higher higher IgG, GMC compared to the unvaccinated. Again, in Belgium, it's the same situation. However, this one here, I want to show you the antigenicity for tetanus and diphtheria as well as. Tetanus and diphtheria, it has been shown here. If you look at vaccinated and unvaccinated in this two graphs, which is in the top and in the bottom. The first one, it's just after the baby born, which is 0. Baby born, now they have taken a sample. And after 2 months of birth, they have taken another sample. So the first one here and to the left is after 0 months, and then 2 months later on. As you can see, in tetanus, okay, it was the same between vaccinated and unvaccinated. However, in diphtheria, it wasn't the same. If we look at, this is after 0. However, after 2 months, it shows clearly for diphtheria that vaccinated were higher. Okay, let's go down to the bottom graph, again to the left, 0 month and then 2 months. If you look at the 0 month, for the 3 main antigen that is available, because it's not a whole cell, it's a cellular vaccine. So the beta-toxoid, filamentous and Bertactin, as you can see, it shows significantly higher immunogenicity to the vaccinated mother compared to unvaccinated after 0 month and after 2 months. Okay, so as immunogenicity here, what's about the timing? Because I have mentioned something about timing in Thailand, and they said that the longer period between the delivery and vaccination, the better actually result and the better efficacy. So here, again, is the same thing. Now, I want to show you that they have measured in Aboraya here in this study, 31 to 36 weeks. In Australia, they have looked at 28 to 32 weeks. In Switzerland, they have looked at 13 to 25 weeks compared to the more than 26 weeks. So they have went down to 13 weeks. And then in Thailand, they have went to 26 to 30 versus 31 to 36 weeks. All of them were high, to be honest. All of them were good, especially in Switzerland. What I want to say here, in infants born to mother vaccinated less than 15 days before delivery, beta-toxoid and filamentous level were substantially lower. So we have to go far before the delivery. We should not go very early to the delivery. That's very important. And this is again confirming what we have said previously in the Thailand study. Okay, prospective study reporting safety. Now we have seen the efficacy. We say that, okay, we have to vaccinate. Longer period before the delivery. We can take actually different perspective, but however in Saudi Arabia, as Minister of Health, they have said, it's 27 to 36 weeks. So this is the 32 weeks, this is confirmed. Now, what's about the safety? Safety have been measured in Switzerland, in New Zealand, in USA, in Belgium, as well as another study in USA. All of those different actually pregnant women and different actually between comparison to vaccinated and unvaccinated. And all the outcome shows here that there was no increased risk of adverse event during in women that they have received the vaccination versus not vaccination. Safety on Tdap vaccine administered during pregnancy is another actually proof here from Argentina, which has maybe in one of the speakers, he showed actually the uptake there. It's almost like 70%. In Argentina, both vaccines that demonstrate a suitable safety profile, no serious adverse events for fatality have been reported. And it was more than 1.3 million doses was distributed in Argentina. So over 1.3 million doses, almost there was no adverse events reported during pregnancy. Okay, this is a conclusion for the safety. As you can see here in safety data are often aggregated, all Tdap vaccine, therefore it cannot always be determined which comes associated with the use of Tdap. One prospective study examined local and systemic adverse events and showed that Tdap in pregnant women was well tolerated. Third, 3 prospective studies did not identify any adverse maternal or infant outcome when Tdap were given. Retrospective studies support the safety of pertussis vaccination in pregnancy, and out of 3 retrospective studies that examine risk of chorioamnionitis, only 1 identified a small but significantly increased risk of chorioamnionitis, but not preterm in birth. This is very important because preterm is an issue that we try to avoid, but in Tdap in particular, there was no increase in a preterm birth. This was really another, just confirming what we have, our previous speaker, they have just presented, that thanks God, Saudi Arabia, alhamdulillah, we are one of those countries that we have implemented Tdap maternal immunization in our schedule, which is we should be really proud of, and we should help our community to be protected against pertussis and to support the policy and the guideline that has been implemented for the safety of to prevent the diseases that Minister of Health they have targeted against pertussis during the first 2 months of infant born. Thank you very much. This is my presentation. Thank you.
Thank you so much, Dr. Khalaf. And now we'll open the floor for quick Q&As. And for that, we would like to invite all the speakers to be on the stage here. Dr. Arua. Dr. Gharid and Dr. Mansour. And I hope that Dr. Mohammed Thaniyan can join us virtually. Dr. Gharid is not here. Okay. We'll open the floor now for the attendees. Dr. Aula, thank you so much for being with us here, Dr. Aula. Dr. Ala Babli, she's representing the head of the Saudi Society for Family and Community Medicine, Riyadh office. So I will leave the floor for you, Dr. Ala.
Thank you very much for this pleasant lectures and important actually topic. I think one of the challenges we are facing in primary health care or family medicine in general, we are the first line in having prevention for the patient. Actually, till now, I think the major challenge that the physician, they are not recommending these vaccination for the population, for high-risk population. Actually, a community lecture, I were talking about things related to health in women. One of them, I raised that vaccination. Okay, so I asked a question, how many, almost there was like 30, 35 women attendees. I asked them, again, a very important point, all of them, they were highly educated population. Okay, I asked them, how many of you had the influenza vaccine? Okay, during the last year, none of them, zero. Okay, I asked them why, they said because we want to give us for our natural immunity. Okay, so the misbelief till now among the community about vaccination is very high. We need, as physicians, to change our attitude of receiving the vaccination. If every lady or every high-risk or mandated age for vaccination heard from the primary care or the caregiver in primary health care or in the appointment following either pregnancy or regular visit in the primary health care that you need to take this vaccination, if they heard it every time, this will change their attitude of having vaccination. I think the main barrier, as Dr. said, the main barrier, it is not in the perception of people. The main barrier is in us as primary health care providers. If we don't change our attitude toward recommending the vaccination, nothing will change. We are the first line. I think these lectures are very essential to increase our knowledge and change our attitude regarding this behavior so it will be changed in the community. Thank you very much again for this very important topic and very important preventive measures. Still now it is underestimated.
Thank you so much, Dr. Ala. Any comment from here? Otherwise, I'll do my comment. Please. Okay. Thank you, Dr. Ala, for this wonderful thoughts. And in fact, it reflects the reality of what we do and what we get in our primary care setup. There is one of the study that showed that the contributor for the failure of the management of any disease or even vaccination in healthcare system, there are three contributors, three stakeholders. One is the patient, the other is the doctor, the third is the healthcare system. And they have divided the contribution in certain percentage, which is really phenomenal. The contribution of the patient is just only 30%. The contributions of the healthcare system is just only 20% and 50% because of us as a physician. We don't pay a lot of attention to the patient idea, concern, and expectations. We don't try to change the mindset and the false beliefs and the misconceptions of the patient, and we let the wrong information spread across the community, and finally we will get a resistant patient to take the vaccine in front of us every day in our clinical setup. This is one of the drawbacks. So they call it clinical inertia. But again, there is another perspective from the patient perspective. We have to look into educating people and the community and making them partner with us to disseminate the positive informations and to elevate this kind of thought. And one of the Tdaps and the other vaccinations, they have been accused to cause certain disease like autism and others, and we encounter this kind of problems all the time. But I think we have to learn how to do a motivational interviews and to convert those patients from the vaccine hesitancy to be our ambassador to do a vaccine recommendations. And then the healthcare system that we have to adapt to bring all the patient and the doctor in the proper encounter and to make that the value of this encounter of having the patient who need the vaccine to have the vaccine without missing it. So I think it's an ecosystem that has many stakeholders, and finally we have to play our role as a family physicians or as a primary physicians, defending our health as the first contact with patients. Any thoughts, Doctora?
Thank you.
I would just like to add, we were discussing that involving women in education, like we need to make leaflet for them in Arabic explaining the disease, because many, they don't know what is this disease and what is the implication of not taking with all the healthcare workers to do this leaflet explaining, and maybe some campaign to explain what is this vaccine and what is the importance of it.
Okay. Thank you. Any other questions from the audience? Yeah, we have one question over there, please. If you can introduce yourself, Doctora. And Mike, please, can you give the mic? Mike. No, here first. Malish.
Assalamu alaikum. First of all, thank you for all the speakers for raising awareness on such an important topic. My name is Almah Shmaisi. I'm a fresh Saudi board family medicine graduate. So my question is, as a new mommy and as a fresh graduate, I noticed that there's quite a hesitancy for taking the vaccine, as you mentioned, doctor. What is my role, or how can I educate my patients on that topic? Especially since I created a group to support the new mummies, and I noticed that there's quite a hesitancy because the exchange of false information regarding specifically the side effects of the vaccine itself. So how can we prevent that, or how can we raise awareness regarding that?
Okay.
Well, thank you very much, Doctor, for raising this. This is really very important. Well, hesitancy is something that we are facing. I mean, I have seen it, and we have tested in 2020. There was a national actually study run by Wiqaya, which is a public health authority on vaccine hesitancy, between public and SCBs. And what was surprising really that SCBs, they have rule actually in hesitancy, so hesitancy was there. Okay, it started with the MMR and the issue of autism, but then it has been spreaded all over the COVID, etc. All of this. Coming to the very important point that, yes, for the side effects of the vaccine, I mean, vaccine I've just shown it in 2 slides here related to the vaccine safety. And it has shown actually with the large number, I mean, I'm talking about just in Argentina, it was 1.3 million pregnant women, they have been vaccinated. And all of those 1.3 women, there was no single, adverse event that has been reported. Not only this, in another part, which is, in US, they have just again tested against something very important again, which is the preterm. Preterm delivery, it's a major issue because preterm means increasing number of deaths. Because neonatal care is not the same everywhere around the world. So some countries, high-income countries, they might have neonatal care, good neonatal care, so the preterm could have really good, actually, life expectancy, while in other parts, no. So again, preterm was not really associated with any preterm. What I want to say, those kind of data, it has to be communicated, maybe in very simple language, because if we are going actually to talk like this to them, it might really lead to more questioning the issue itself. But very important, in order to overcome all of this, it is how important it is to the babies. It's very important. So if they will think about, the importance for the baby, the prevention of pertussis that could lead to pneumonia and hospitalization, and God forbid into the death, that will increase their belief. This is number 1. Number 2, we'll go again to the safety after that. But again, let's go back to the same issue. We have, first of all, to implement the issue related or to prevent the issue of hesitancy, which is really something that might not really be genuine for Tdap itself alone, but it could be really for all kinds of vaccines, not just for Tdap. You will see it once she has this one, it means that she has another thing related to vaccination later on, not just for in particular Tdap and maternalization, but might be really for MMR, she might have, another issue. I believe this is something that, and I've attended this week a meeting with the Wiqaya themselves, and they are going actually to launch a campaign for vaccine hesitancy in Saudi Arabia. Thanks God, it's not very high, like another part of the world. I have witnessed in Canada, actually, it was in the main road. In Toronto, it was really in the street, and I don't know who paid for that, but vaccine hesitancy was there. So I believe that as healthcare providers, we have a role to prevent this one from being spread, because we have very successful vaccination program in Saudi Arabia. It's one of the very interesting, I can say that it's world-class vaccination program, and we have been very successful in preventing a lot of diseases and controlling a lot of diseases. We don't need to see measles again, and we don't need to see actually polio again. This is really very important. Thank you again for the question. Thank you.
Thank you. Any other thoughts? I think education is a very important part, to convince the mothers that this is a very important and safe vaccines. And, if she refuses, we respect the patient autonomy, but at the same time, the next subsequent visit, we have 8 visits. Every time you try to convince her, give her the tools and the proper information, ensure that she will be having a safe pregnancy, and this is a protection for her baby. So her baby is taking a vaccine before the birth, so as if it's a kind of protections and enhancing the immunity. And then the communication skill is very important. They always say the good communicator has 3 important things. He has an open mind, receptive ear, and empathetic heart. So we feel for they have this kind of concern, and we will tackle it as it goes. So building a good doctor-patient relationship and involving the other members of the team, like midwifery here and other members of the team, the educators, they have another role, not only the physicians. So with this, we might change, the concept, the perception of the people, and try to find some of the mothers to be the advocate, and they have some kind of a group discussions with the other pregnant ladies just to convince them that this is, so it's not the role only of us as a physician and a medical team, but we can bring people from the community to advocate for kind of important interventions. Okay, any other questions? We have a question here, please, go ahead.
Hello, good afternoon. I'm Shaira and I am a nurse. As a nurse and giving education to the patient, are there any situations of the pregnant women with comorbidities where Tdap may not be recommended?
Once again?
Tdap is not recommended?
Yes.
What contraindication for Tdap?
Yes,
Right.
comorbidities or any.
Any
Comorbid?
Contraindication.
Contraindication.
any contraindication
okay.
of the Tdap?
Well, it might be allergic. If she is allergic, this is the only thing that we are thinking about it. Or if she has something like blood disorders that could lead to bleeding. This is another issue. Other than this, actually, it's like any other vaccines. Yeah. Thank you.
Okay, any other questions? Yeah, here, we have here, 2 questions here. تفضل دكتور.
السلام عليكم.
عليكم السلام.
دكتور أحمد سيد, community medicine. After 36 weeks, is there any role to catch up if the lady يعني
Yes.
Yeah, well, thank you very much. I've just presented this one. It was really, it was one of the studies that has been conducted in Switzerland. Yes, it could be, but again, this will bring us very close to the delivery, in which that it has been shown that close to delivery, it will not give the same impact of having it earlier, but there will be, yeah, but it won't be really the same efficacy compared to the earlier period, after 36 weeks, yes.
Okay, we have another question here. دكتور تفضل. Mike.
Assalamu alaikum, Dr. Ahmed, family medicine consultant. Thank you for all speaker. My question related to doubling dose of Tdap during pregnancy. If I have patient came to my clinic from, maybe she is non-Saudi and she doesn't know if she received or she doesn't know if there is duplication for the dose or any contraindication.
No contraindications.
No. Well, there is no overdose with vaccine. This is very important.
No, she doesn't know. I have already one patient like this. She is Syrian patient. She doesn't know. She received, I don't know. They give me one injection, but I don't know if there is a vaccine or not. So she came during her pregnancy, 26 or 27 weeks, and she asked, I will receive vaccine or no? What can I answer here?
She didn't receive it.
She doesn't know.
She doesn't know. Okay. Well, this. Yeah. Thank you very much. Well, and in the pregnancy, actually, they gave me flu. She might already took flu, and this will be Tdap. So this is really, she must not really aware that what she took exactly. So this is fine. Even that, let's say that, even that she took Tdap previously, and this is a second one that she has taken it. Tdap vaccination, this is not a live vaccine. This is not actually, bacteria itself. No, it is an antigen. It's a part of the bacteria itself. And in fact, that there is no overdose of vaccination. There is overdose. So yeah, it should be safe.
So I can give her again.
Say it again.
Give her. I will give her.
Yes.
Okay.
Yes.
My second point, if there is any data, Dr. Roa, if there is any data related to mom came to my clinic, she didn't receive during her pregnancy, she didn't receive Tdap vaccine. If there is any data to give the neonate her first dose of Tdap with hepatitis B after birth, or I have to wait to first 2 months or first injection of vaccination?
It's according to the guidelines of the vaccine, to the newborn. You give the hepatitis usually in the hospital, and then they can wait and take the Tdap according to the schedule.
Even if her mom didn't receive the Tdap?
Yes.
Wait also?
Yes.
Okay. Third point, sorry for taking more time. Third point for our role as a primary health care physician, we have vaccine already available. We have patient and we have a physician or nurses for vaccination, and we have shortage or always we have low statistics for vaccination rate. I think we talked about too much about that point. I think we need a type of study, and that study will conclude and give to us as physicians a type of flow chart. This is my suggestion. What type of flow chart? I have patient, this patient, for example, is from Riyadh. Patient from Riyadh may be different from Jeddah patient. Like, for example, and I have patient low educated, and I have patient high educated. This patient refuse for she is fear of side effect. She has have wrong beliefs about vaccine. I want flow chart. If you have met this type of patient, as I am a family physician or primary health care, you have to advise her like this. If she refuses, move to another side, move to another point. I think this flow chart will help us, because we know you have to persuade the patient. Okay, she didn't listen to me. You have to make good relation. I have good relation, but also she refused. So my flow chart will, if she refuses that side, you can go to other side, another side to another side, and so on. Thank you.
Actually, we have the adult immunization program, which stated clearly the importance of having this Tdap in certain period of time. So this is well documented. But again, if there is certain model of care to enhance the coverage of vaccine in adult in general, using automation, using your HI system, so to flag those people who are eligible to have the vaccine and they are not getting the vaccine. For example, in my hospitals, we have adapted vaccine and other health issues in the triage of the nursing triage. When the nursing taking the vital signs, they ask the patients about certain vaccine. If the patient did not take the vaccine, they will flag the system. So the system will be flagged across the hospital, across the board, that this patient is eligible. And then this will generate the SMS system, SMS message to the patient, please, you are due for the first dose or the second dose, for example, of hepatitis B or whatever. And then the alerts will be received by all the physicians, regardless of their specialty. They are not only family physician, but also orthopedic, ophthalmology, OBGYN, and so forth. So every point of care will be a checkpoint for the patient to receive the vaccine. So we don't want to have a missed opportunity of having that particular patient leaving the hospital without having the vaccine. So this is how to adapt your internal system. And then the whole system across the nation will be connected, to ensure that those people, wherever they go, they will be picked up from hospital to another, from primary care to another polyclinic. So this is the system. But again, we have to enhance our role as a primary care physician, as a gatekeeper of the healthcare system, to make sure that those people are not getting missed, because we are the one who is providing the preventive services. And now we are in the era of moving from intervention to prevention, from disease to health, from illness to wellness. So we don't want people to get sick. We would like to promote health and wellness for our patients and community. All right. Any other questions? Yes, we have one question there. Mike, please. Here. Okay, we'll go here and then there. Go ahead.
Good afternoon. I am an IVF nurse. Regarding our patients, IVF patients who are pregnant, is the Tdap recommended for an IVF pregnancy?
Yes, definitely. Yeah.
Why you are asking regarding IVF? What's the problem with
It could be a high-risk pregnancy.
It is high risk, but it is safe. It is safe. So why not?
Yeah. طيب, we have a question here, دكتورة تفضلي.
Assalamu alaikum wa rahmatullah. I am Dr. Ruby Rafiq, family physician. I have one question. It has been a misconception, any relationship of the pertussis vaccine with the induction of the epilepsy or conversion in the newborn. Is there any clear study or valid study?
Association between the vaccine and
vaccine
epilepsy.
associated with the conversion, induction of conversion.
No. Okay, there is no evidence at all. There's nothing reported to have adverse event of the vaccine to have an epilepsy. Okay. Do you have any documents?
Actually, during study we have read about this. this might be induction of the conversion in the newborn. So people, parents especially, they have misconcept, all right, this is unclear.
No, I don't think this is true, Doctora, because there is no evidence for this. And the vaccine has been shown to be very safe, efficacious, and there is no adverse event of whatsoever. So I think this will...
You mean after maternal immunization, conversion could increase?
Yeah, it is.
No, I don't think that
There
this
is
is...
no evidence of this.
If there will be, you know, I mean, if I can recall that there might be really increase, or I can say that might be really one of the side effects for a convulsion. If they have tendency, higher tendency for epileptic attack, this could be really at when they will be taking the vaccine at school entry, for example, after 2, 4, 6, and then 18 months, because at this age might be really, but before that, no. Even with a 2 month, 4 months, 6 months, which is the full concentration of Tdap, TDDBA, which is as hexavalent, there is no, increasing risk of convulsion. So by default, that given it at maternal immunization, there will be no link. It could be really happened, but immediately after vaccination. But this is 2 months after.
It means there is chances that it may cause the conversion later on if there is tendency.
No, but not after maternal immunization. It could really, I said that, it could be really having with the full concentration, not with a low concentration Tdap, which is the one which we are talking about right now. This is because it's a different product here. The hexavalent is a full concentration TDBA, while this one is a lower concentration, 1/3 exactly of the content of the antigen here.
Actually, previously without the maternal immunization, pertussis vaccine was considered might induce conversion later on. As you're saying, it is the maternal immunization, there is no link. This is a different thing.
But I have no study, to be honest. If you have something that I can share it with us, that will be really great. Thank you.
Thank you.
Okay, I have a very interesting question from the online audience. It's a case study, in fact, or a case scenario. Gravid 4, para 3 in 13 weeks, gestational, accidentally, she stepped on a rusty nail. Lady cannot, but she received the tetanus toxoid. So can we give her the Tdap? Yes, we can give her.
Yes, we can,
yes,
of course.
Even before, because she's in 13 weeks.
Absolutely.
Yeah,
Yes.
So we can give her the Tdap, and this intervention or measure could be given as a part of the active wound management as well.
Perfect.
So this is a scenario where we can give the Tdap before the 27 weeks.
Absolutely.
Which is usually it's recommended between 27 and 37 weeks.
No.
Okay. Any other questions from the audience? Yeah, Doctor, تفضل. Yeah.
Assalamu alaikum. I'm Dr. Noha Zera, family medicine consultant. Thank you for all speakers.
فين دكتورة فين؟ اوكي تفضل.
My question about is there any recommended interval between pertussis infection and vaccination of Tdap? I mean, if a person already infected by pertussis infection, we know pertussis passes through 3 stages: convalescent and paroxysmal and catarrh and paroxysmal and convalescent stage. My question is, when can I vaccinate the person after infection?
Vaccination after infection.
Yeah. Well, as you know, that pertussis, natural infection, diphtheria, tetanus, they will not give long life immunity, as varicella, for example. So there's no life immunity. It's usually waning after some time. But in a normal persons around 20 years, it will stay for 20 years immunity. But again, it goes down dramatically with some people. So I would say that even if the mother, she has taken it this one and another time, after maybe I can say 2 weeks or 3 weeks or even 1 month, there will be no harm. It will boost the immunity. So there will be no issue at all. Exactly. Yeah.
تفضل دكتور. Yes. Go ahead.
Assalamu alaikum warahmatullah. Dr. Ahmed Yusuf, I want to ask a question regarding if we have patient as a pharmacist or the first line health care. If we have patients regarding to the question that was asked online, maybe a patient step on iron, then there was a wound on the lung and she's pregnant for 13 weeks. But this patient, she has a misconception. I want to go to the hospital, and she's very very satisfied in taking medication rather than taking a vaccine. What are the recommendations that we can give to this patient just to keep her safe until we can advise and come to maybe a level of agreement that she will later on get the vaccine?
Yani, I can't hear the question. Yeah, please go ahead.
He mean patient who, the same scenario, but patient, I explained to her that she needs this vaccine, she refused. So this is patient autonomy. And for me as a healthcare, I will give her the advice. I will tell her if she didn't take the vaccine, what will happen. So if she will refuse, we cannot force anyone to take it. So just documentation. I usually, as a physician, I always ask the doctor that document everything, every scenario happened between the patient that you did your job in this case. And if she refused, you cannot do anything.
If she refused, you have to accept her refusal, but you have to reinforce the wound management plan to be more aggressive, not to have the infection, and tell her exactly what are the signs or red flags. If it happens, this demonstrate that she got the infection and she has to come to you as a physician to tackle the infection. And whenever she comes, you frequent follow-up to make sure that she's not getting into complication because of the infections. So this is a common dilemma that we encounter if there is a refusal, but we have to take the other part of the management of the wound or the management. Any other questions?
So that means at the moment we have no medication we can give that comes to the same level as the Tdap vaccine. There's no medication at the moment that we can give?
There's nothing.
Not that it could cover the Tdap vaccine, but at least she can keep her safe until she agrees to take the vaccine.
The regular management of the wounds, the usual way. Any other questions? No more? Okay, so I think by coming to the end of this scientific sessions, we have shed light on the importance of the Tdap as an important immunization that we have to consider for all our ladies who are pregnant between the weeks of 27 to 37 weeks. And we have learned also that the mortality and the morbidity increase with pertussis infections on those infants below the age of 2 months. And unfortunately, all the series of immunization for the infants started after 3 months of age, and there is an immunity gap. And this immunity gap will predispose all the infants to become more vulnerable for these kind of infections. So that's why we are talking about the maternal immunization that will cover this and bridge this gap of immunization by having the proper protections for those babies and those infants in the first age. And we have also demonstrated the burden of our healthcare system. And in one of the studies in the state, 50% of those babies who have been infected, they need hospitalizations. Majority of them, they were below the age of 3 months, and the remaining were between 3 months and 6 months. Not only this, but also the complication which has been reported to be apnea, pneumonia, encephalitis, and seizures, and about 50, and the mortality is 1 in 100 infants. So this is a huge burden. So that's why we have to reinforce the importance of vaccinations for maternal groups of our populations. And we have demonstrated in this scientific session also the safety, the durability of the vaccine, and there is no reported major adverse events, and the vaccine is safe and well tolerated by most of the pregnant ladies. So with this is just to conclude the most important part. So I think as a primary care physicians and as a healthcare providers, we have to take our role and to jump on this major responsibility to enhance the perception of our patients and to elevate the hesitancy of vaccine and to improve the recommendation of vaccine by us and to ensure that our healthcare system has well set to bring this kind of importance outcome into the practice of our in the practice of our primary healthcare to ensure the safety of our pregnant ladies. With this, ladies and gentlemen, I would like to thank on your behalf all our colleagues who have been contributing to this scientific event. We have Dr. Mohammed Thaniyan, Dr. Gharid Dosari, Dr. Ro'a Twili, and Dr. Mansour Khalaf for their contribution, for the great information that has been disseminated in these presentations. And those who have been attended online for the wonderful questions and the question that really reflect the practical part of our practice in family medicine. And I would like to extend our thanks to the sponsoring company, GSK, and the organizer and the FEXs. And I would like to wish you a very wonderful day and a good practice. Looking forward, inshallah, not to miss any pregnant lady who has the potential to have the vaccine without having it next day, tomorrow onward. Thank you so much and have